Great. Well, thank you, Andrea. Thanks to the PMD Alliance for continuing to host this. And I know we're into, getting into the winter months in many parts of the country, and the world is, continuing to be the pandemic is raging in many parts of the world. So hopefully everyone's staying physically distanced, trying to socially connect in whatever way you can, picking up the phone. These virtual support groups are a great way to connect with each other and, think about those that are less connected even than you. So think about how to reach out to them as well. So it's with great pleasure that I bring Professor Gershanik all the way from Buenos Aires, Argentina. I wish we were there together. I'm such a fan of so many things that are Argentinian. And I saw Professor Gershanik speak at the Movement Disorder Society, which this year was fully virtual. And I thought it was an amazing meeting and was just inspired by his talk there. I ended up connecting with him I sent him an email, and he was kind enough to chat with me a little bit about some things that he's been interested in, and was kind enough to take an hour of his time today and teach us all about dyskinesia, which has been an interest of his from a research perspective. He is a true Renaissance man. He does a ton of great things. He's very supportive of patients and advocacy groups there in South America. He really has some cool stories to tell about the history of Parkinson's disease. It's been, taking care of patients for decades already. And even though he looks very youthful, I guess he was there even at the start of some of the therapies that we have. So he'll teach us a little bit about that journey. He was the president of the Movement Disorder Society a few years ago, and continues to give some amazing talks that are really inspiring us as clinicians. And so it's just been a lovely thing to hear him speak. And I wanted him to bring some of that wisdom and enthusiasm for patients here on this call today. So thank you so much, Oscar, for joining us. And he is based at the Favaloro Foundation at the University Hospital in Buenos Aires, Argentina. And so thanks, Oscar, for joining us. Welcome. Maybe you could tell us a little bit about your journey to becoming, first of all, a doctor and then a neurologist, and what inspired you about Parkinson's disease and why you take care of these patients this many years later.
Okay, first of all, I would love to thank you for the invitation. It's for me a pleasure to be talking to you and to all your group and all the patients throughout the US and different parts of the world. I'm very familiar with this type of conversations because I've been involved for many years with advocacy groups here in Argentina, and also with the WPC, the World Parkinson Congress, which is also more dedicated to patient interest than other meetings. If you want to know about my journey, it goes back to, I would say, to my high school years, because when I was a teenager, I was able to travel to the US as a foreign exchange student. I lived in Iowa. I did my senior high school year there. So that was my first contact with the US, and that allowed me to perfect my English. And that was a very good tool that was quite important in my academic years. And actually, my interest in Parkinson's disease and basal ganglia disorder started very early on in my medical school. When I was in first year medical school, I had to write a kind of a monograph or thesis, and I was interested in the central nervous system, and I wrote on the basal ganglia function. You know, the basal ganglia is the structure of the brain that is affected by Parkinson's disease. And I was interested in the basal ganglia because of its complexity. When I was younger, I never thought I would go into medicine. I thought I was going to be an engineer. My uncle, my mother's brother, was a highly successful engineer, and he was kind of my role model, whereas my father was a pediatrician. And I don't know why I never thought I would go into medicine, even though I was used to, in everyday life, to be in contact with my father's patients and with his practice. And when it came the time to decide on a career, I suddenly switched from engineering to medicine. And when I was studying anatomy and physiology, the basal ganglia had this complex circuitry that reminded me of my interests in engineering. And so I decided to go deeper into the knowledge of the functioning of the basal ganglia. That's why in second year medical school, I wrote this monograph on the intricacies of the basal ganglia. That was my first exposure. And from then on, I decided that I would pursue a career in neurology, and not only in neurology, but in the subspecialty of Parkinson's disease. Because at that time, when I was studying, there was no such thing as movement disorders as a subspecialty. You know, the subspecialty of movement disorders came into being in the 80s, and I graduated in 1972. So there was no such thing as movement disorders. It was Parkinson's disease. And in 1975, my mentor and the chairman of my department of neurology was invited to chair the meeting of the Argentine Neurological Society. And one of the faculty that was invited for that meeting was one of the pioneers in Parkinson's disease, you know, Melvin Yar. Melvin Yar has the name of the Henan Yar scale. So he was one of the first ones to be interested in Parkinson's disease in a scientific and academic way and with true scientific methodology. Actually, he was the first one to publish what happened to patients that were introduced to this new wonder drug called levodopa. And he was invited to give a talk in Argentina, and there was supposed to be simultaneous interpretation of his lecture for the audience. And the interpreter approached Melvin Yar and said, "Do you have anything written?" And Mel Yar, who was kind of gruffy, you know, he was not very easy to get along with. He said, "I never write anything for my lectures. I have everything in my head." And so the interpreter said, "Well, if you don't have anything written, this is a very specific topic. I'm not going to be able to translate your talk. So I quit. I resign." And the chair of the meeting, my mentor, was kind of desperate and said, "Oscar, I know you are quite fluent in English. Do you think you can translate Mel Yar's conference?" And I said, "Yeah, I can do it. I cannot do simultaneous translation, but I can go up on the podium on the stage, stand at the side of Mel Yar, and do sequential translation." And well, and I did it, and it came out quite well. And everybody was surprised because the audience thought that that had been prearranged like this, as it went so smooth. And Mel Yar was kind of surprised that I was so knowledgeable about the basal ganglia. And I was just a very junior neurologist doing my residency training. And he said, "How come you know so much about the basal ganglia and dopamine and levodopa?" At that time, he was presenting Cinemet, the miracle of the combination of levodopa with dopa decarboxylase inhibitors. And so everybody was fascinated with this new combination of levodopa that was so effective. And he said, "Are you really interested in the field of Parkinson's disease and dopa metabolism and levodopa?" And I said, "Yes, this is one of the things I want to do." And he said, "Why don't you come to Mount Sinai to work with me?" And I said, "Well, I surely I'm interested in doing that." And a year later, I received an invitation, and I spent some time at Mount Sinai, and I did basic research there. And I had the chance to meet I think one of the greatest guys in the field. Unfortunately, he has already passed away, Roger Duvoisin. Roger Duvoisin, not only was he a pioneer in Parkinson's disease, he was the promoter of the search for a genetic cause of Parkinson's disease. And his group was the one that discovered the first genetic form of Parkinson's disease. And when I finished my time at Mount Sinai, I came back to Argentina. And soon after I arrived, I received a letter. At that time, there were no internet, no emails, no WhatsApp, nothing of that sort. Everything was via mail, regular mail. And Roger Duvoisin was invited me to go back to the States to the newly created Department of Neurology at Rutgers Medical School, what is now known as Robert Woods Johnson. At that time, it was called Rutgers. And so I went back to the States. And at that time, I was not only invited as a fellow, I was invited as an associate professor of neurology and neuropharmacology. And I did teaching and clinical work and basic research in dopamine receptors. And that was my beginning in the career, in a dual or two-hat career. On one hand, my clinical interest, and on the other hand, my basic research interest. And that's how I became interested in this field. And from then on, everything was like a roller coaster. You know, I started attending meetings, publishing papers. I got to know Stanley Fawn, going to the American Academy of Neurology. And in the 80s, I received another letter from Stan Fawn inviting me to become a member of the International Executive Committee of the recently created Movement Disorder Society. And I started as a member of the International Executive Committee, and I climbed up the ladder within the society. Later on, I became the treasurer of the society. And then in 2015, I was elected to become the president of the society from 2015 to 2017. And I'm very active in the society. I'm the chair of the International Congress Oversight Committee. I'm advising the educational roadmap in our website. And I'm the advisor for the creation of the African regional section of the Movement Disorder Society. So this is in brief my
Amazing.
career in the field.
Well, I think, that's an amazing sort of story of almost luck in some ways to have been in the place where the interpreter quit. But I think, you would have shone anyway, I think, and shot up in all of these ranks, regardless of if you had translated for Dr. Yar or not. But just such a cool story, I think. So thank you for sharing that with us. And Oscar, I think, your work at the Movement Disorder Society has been really important. And we've had in these series of talks, Omatola Thomas, who is very, active with the PD Avengers and trying to get the African, countries to have access to these medications. And I think, you've really put the, South America and made the Americas, unified in many ways, and some of the hopes that we're trying to create with the Pan American Society as well, of the Movement Disorder Society. So I really, commend you for your work and great causes that you've been behind and getting really great things done as well. So, so Oscar, I wanted you to have some time now to teach us a little bit about dyskinesia, because I think you've seen literally, I think the sort of history, and I think this pendulum, even in the 20 years that I've been a doctor of taking care of patients, where we were having levodopa-phobia for much of, when I first started training, and now sort of we're much more happy with, using these dopaminergic medications. And then also I'd like you to have a little bit of time to teach us also about some of the lifestyle and approaches that you think help patients, in their day-to-day sort of lives as well. So I'll give you some time to maybe teach us a little bit about your approach and the dyskinesia sort of concept, and what you think kind of causes it and how we should approach that.
Okay, well, there are many ways to look at the problem of dyskinesia. One is first to understand that this is a very complex clinical phenomenon from a phenomenological point of view, because people try to think about dyskinesia as a uniform phenomenon. And it's very complex, very diverse, and there is a range of clinical phenomena that have different pathophysiology, and different forms of presentation. So I think it's important for the patients to understand, first of all, that dyskinesia is a long-term complication of the exposure to levodopa. This is not a symptom of the disease, is an abnormal reaction to the effect of the medication on the brain. This is a very important concept to bear in mind. Second is that dyskinesia, as I said before, is not a uniform phenomenon. There are very different types of dyskinesia. You have what is called the on-period dyskinesia and the off-period dyskinesia and the diphasic dyskinesia. These are quite different. The off-period dyskinesia coincides with a period of absence of the effect of levodopa. And the phenomenology, it's quite peculiar because it's mostly dystonic. Dystonic meaning muscle contraction. It's a sustained muscle contraction. And the most common of the off-period dystonias is the early morning foot dystonia. People wake up early in the morning, get out of bed, try to start walking, and as soon as they start walking, the most affected foot goes inward and it can become painful. This is what's called off-period dystonia. The on-period dystonia has very different forms of presentation. The most common being the choreic type of dyskinesia. This is kind of a dancing-like movement, oscillations of the trunk, oscillations of the limbs, and that's the most common type of dyskinesia that occurs during either the maximum benefit of each levodopa dose or during the entire on period where the patient is under the effects of the medication. But there are also other types of on period dyskinesias like jerky movements of the limbs, jerky movements of the head, etc. And then there is one peculiar type of on-period dyskinesia that it's called peak dose dystonia. And this is characteristically affecting the perioral muscles, the muscles of the mouth. And people, when they reach the maximum effect of levodopa, experience a contraction of the muscles around the mouth. And that interferes with speech and articulation. And then you have the biphasic dyskinesia. This is a very complex type of dyskinesia, and it appears at the beginning of the effect of a levodopa dose, disappears during the period of maximum effect of the drug, and then can reappear in the period where the effect of the drug tapers off. And this is the most complex, the most debilitating, the most incapacitating, because these are very complex, jerky movements that predominantly affect the lower extremities, like repetitive movements of the legs. And they are very, very debilitating and incapacitating. So every time we face with a patient with dyskinesia, we have to be aware of these different types of dyskinesia because the mechanism of production of these dyskinesias is quite different. The off-period dyskinesias are due to the lack of effect of the medication. The on-period dyskinesia are because of an excessive effect during the period of effect of the medication. The on-period or peak dose dystonia is very difficult because it appears at the peak of maximum effect of levodopa, and it's very difficult to manage. And the biphasic dyskinesias that some people associate with an excessive effect of medication, the fact of the matter is that these dyskinesias are because the patient cannot achieve enough levels of levodopa in plasma to have the full effect of levodopa. So these biphasic dyskinesias actually respond to increases in the dosage of levodopa. So we cannot lump together all the dyskinesias and think this is a very simple problem and it's because of an excessive effect of the medication, and just by reducing the medication you solve the problem, because this is not the case. And it's not also such an easy explanation that it's an excessive effect of levodopa, because sometimes patients develop dyskinesia with very low doses of levodopa. So this has to do what it's called the therapeutic margin or the therapeutic window. The therapeutic margin or the therapeutic window is the difference between the dose that provides benefit with the dose that produces side effects. If that distance is very narrow or very short, the dose that you need to have benefit is the same dose that produces the side effects. So that's why sometimes it's very difficult to manage dyskinesia. So this is an overview of the clinical phenomenology. Concerning the factors or the risk factors for the development of dyskinesia, we know for a fact that younger people are more prone to develop dyskinesia than older people. So in younger people, one has to be particularly careful with the use of medications because they tend to develop dyskinesia very easily. Second, lower body weight. Females that have a lower body weight than males are also more prone to develop dyskinesia. It's an important factor. And duration of the disease is another important factor. And in my experience, another important factor that people do not consider as important, but there is significant evidence in this regard, is the way you administer levodopa. And this can be a controversial issue because the manner or the mode of administration of levodopa differs from one part of the world to the other. When levodopa was first introduced into the market, the mode of administration was suggested as 3 doses a day. And there was no explanation uh, or a scientific background to decide that this was the correct way of administering levodopa 3 times a day. And the other thing is that when you say 3 times a day, it may be not the same for one person or the other, because sometimes the doctor doesn't tell the patient you have to take this at regular dosing intervals. And so you find patients that take 1 dose in the morning, 1 dose at noon, and 1 dose late at night when they go to bed. And we know uh, through our research in the mechanism of action of levodopa and the dopaminergic system that oscillations in the stimulation of dopamine receptors, what is called pulsatile stimulation of dopamine receptors, is one of the mechanisms that leads to all the changes that take level and at the structural level in the cell that lead to the development of dyskinesia. So if you administer levodopa in a very pulsatile and irregular way, the chances of developing dyskinesia are much higher. So there has been a lot of research done in other ways of administering levodopa at shorter intervals, 3.5 to 4 hours. So at least 4 times a day or 5 times a day. And to be very precise in the way you adhere to the intervals. And you have to take it every 4 hours, and you have to be very regular. And you have to take the lowest possible dose. These are things that uh, diminish the risk of developing dyskinesia. Mm. Uh, in my experience, this is something that is not shared by many people, particularly in the US and Canada, but it's shared by people in Europe and in region, and in some people in the UK too, is that I sometimes prefer to delay the use of levodopa in younger patients. And in my own experience, when you talked about this cycle with levodopa, uh, I started in the field in the 70s when levodopa was just introduced into the market. I treated patients before Cinemet appeared in the market. So we had levodopa without dopamine decarboxylase inhibitors. So you had to give huge amounts of levodopa, 12, 16, 20 grams of levodopa. Patients did not tolerate levodopa very easily, so the titration had to be very slow and in low fractions of levodopa. But we thought this was a miracle drug. It was the first drug that specifically addressed the biochemical disturbance underlying the clinical features of Parkinson's disease. So we were going to solve the disease. And so we were very careless in the use of levodopa. We gave levodopa to everyone, and we climbed the dose until we reached maximum benefit without any consideration about the risk of developing dyskinesia. And soon enough, people were having these complications. In the late 70s and early 80s, we had the best descriptions of dyskinesia and all these complications due to the careless use of levodopa. And that coincided with the development of dopamine agonists. And dopamine agonists were thought to be less powerful in the sense of achieving clinical benefit, but also less powerful in their ability to induce dyskinesia. So people started developing what it's called levodopa sparing strategies. So we started patients on low doses of dopamine agonist, and we delayed the use of levodopa. And some people started also to claim that levodopa was not only capable of producing these side effects, but also was toxic to the brain. On one hand, it improved the clinical symptoms of the disease, but on the other hand, it could be toxic to the cells, to the remaining cells in the brain. And I think this was promoted in part by the pharmaceutical industry trying to put a wedge into the levodopa field and promote the use of dopamine agonist. But there were many scientists that truly believed that levodopa was toxic. And it was in fact in my own research lab that we demonstrated for the first time in vivo that levodopa was not only not toxic for the cells, but it promoted to some extent the recovery of dopaminergic cells. And from then on, the myth of levodopa toxicity was not claimed anymore, was disproved. And so people started back again to get more confident with levodopa. And we arrived to 2019, 2018, where we've gone the full circle. And now we have some of my dearest colleagues in the world, some people that you have interviewed in your series into, that say that levodopa for all, no matter what, whether they are young, they are old, etc., etc. And I'm still a firm believer that in younger people, we have to be quite careful. And I base this not only on scientific evidence, but also on my clinical experience. I've been in the field for 43 years, and I'm not just a consulting neurologist. I see patients on an everyday basis, and some of my patients, I have followed them for 30 years now. I do now that I have seen them from day one until today when they are 30 years into the disease. So it's not that I see a patient every 2 or 3, 4 years referred by the primary care physician. When I started in the field, we used to see these very severe, incapacitating dyskinesias. We had to admit the patients to the ward because it was so severe, the patients got dehydrated. And we don't see that anymore. And in the last 10 years, we don't see as many patients with severe dyskinesias as we saw before. And I think this is because three factors that influence that. First, we are careful with the introduction of levodopa in young patients. Second, if we use levodopa, we use it very carefully at the lowest effective dose. And we are very careful with the mode of administration. We try to use it at very regular intervals, trying to make the patient understand that the more stable the levels of levodopa in the brain, the less chances of developing dyskinesia they have. So these are some of the factors that lead to the development of dyskinesia. And another thing that I would like to underscore or underline is that once you develop dyskinesia, it is very difficult to go back. It's very hard to make them disappear. Not only because there are molecular changes, but because there are genetic transcriptional changes in the cells and structural changes. The cells modify their structure. You know, cells contact each other through what it's called dendritic spines. These are small protrusions in the arborization of the neurons. And when you get Parkinson's disease and you lose dopamine neurons, so there is less dopamine in the brain, there is a change in the structure of your cells. And when you try to introduce levodopa to alleviate the symptoms of the disease, you do not go back to normal. You do not reestablish a normal functioning of the brain. You make further modifications in the molecular cascades and further modifications in the structures of the cells, which are not normal anymore. They are a different abnormal that allows the patient to feel better, but it's the stepping stone for the development of dyskinesia. And these structural changes do not disappear. These molecular changes do not disappear very easily. So when we are faced with a patient that has developed dyskinesia, it's quite problematic. And this is another myth that I would like to address. Again, some of my dearest colleagues, as I mentioned before, think that dyskinesia, it's not truly a problem. And in fact, they go as far as to say that dyskinesia is a measure of success in your treatment of a Parkinsonian patient, because it means that you have achieved a sensitization of the brain such as to provide more benefit. And this is absolutely not true. I mean, I don't think that developing dyskinesia is a measure of success in the treatment of a Parkinsonian patient. Parkinsonian patients with dyskinesia are not, first of all, they do not feel comfortable. they feel discriminated. I can tell you some of my patients taking public transportation have been forced to oscillating and dancing all the time. And people tend to discriminate people that look different. I mean, when you're talking to somebody that is moving and gesticulating and doing bizarre movements, this is easily confused with mental incapacity. And this is a kind of a factor that stimulates social discrimination. And we're not talking only about social discrimination and discomfort. People with dyskinesia find very difficult to dress when they have these movements because it's not easy to button up a shirt or to zip up a sweater, and it's difficult to use your fork and knife when you are eating and you're moving, and sometimes it's difficult to chew the food when you have all these gesticulations. So I don't think dyskinesia is a measure of success. And there are many publications addressing quality of life and dyskinesia, and very few that say that dyskinesia does not affect quality of life. In fact, I would say that there's only one that is often cited by those that promote the success that dyskinesia means in terms of therapeutic objectives. But most of the other publications talk about all these other issues that really reduce quality of life in our patients. So we have to be very careful in the way we use our medication and try to prevent dyskinesia. Because once dyskinesia is there, we only have two or three possibilities. We can reduce the dose of levodopa, which sometimes is not very easy because of what I talked about, this narrow therapeutic window. When you reduce the dose of levodopa, you get rid of dyskinesia, benefit of the drug in terms of your motor performance. You can do fractionation of the dose of levodopa. So instead of taking 3-4 times a day, you go up to 6 or 8 times at lower doses, but that sometimes is not very effective. You can give amantadine, which is the only approved drug in the world for the treatment of dyskinesia. But amantadine reduces only 60% of dyskinesia, and it has another problem. It's not only that it's not effective in 100% of the cases, but it has an anticholinergic component to its effect, and that can affect attention and cognition. So in patients that are old or of advanced age and have dyskinesia, you have to be very careful with the use of amantadine, because amantadine may contribute to further deterioration of the cognitive status. So it's not for all. And the other possibility, it's advanced therapies, DBS surgery, or levodopa infusions. And levodopa infusions are not very easy. I mean, they have to put a tube in your intestines. You have to carry a huge pump at your side. It's very, very expensive. It has limitations in the things you can do in everyday life. You cannot swim, for example. You cannot get into a jacuzzi. You cannot get into a swimming pool or the sea because you have this tube in your stomach and you're carrying that pump. So it's not a very good solution. It's a solution in a relative sense for patients that cannot undergo surgery. And then you have surgery. And this is something, whenever I give a lecture, I always remind our colleagues that we are an international society and the world is not uniform. The world is not the US. and Western Europe. The world, it's wider, it's more complex, it's more diverse, not only in culture, but in resources, in access to medical care. So we cannot take for granted that when we give a talk about what are the opportunities for a patient with dyskinesia, oh, he can have duodopa, levodopa infusions. Tell that to a patient in Africa or in Central America where levodopa infusions are not available, not even DBS, not even surgery. So we cannot talk so easy about we have all the resources to treat dyskinesia because we have advanced therapies, because these are not available worldwide. And even when they are available for some countries, they are so expensive that not many people can afford to have that type of therapies, of advanced therapies. So this is something that we have to take into account when we talk about dyskinesia is not a huge problem. It is a problem. So I think I've said enough, Indu. Maybe you can make some remarks or
Yeah,
questions or some things that you
sure.
would like me to
Yeah,
talk
absolutely.
about.
Yeah, so I think a lot of what you said has resonated in the chat a lot. People are really appreciative of hearing about the different types of dyskinesia and dystonia, sort of the understanding of that, and the way that you explained it, I think has been very helpful to people. And I think a lot of people have been, trying to get a better sense of things, for themselves, I think. So one of the questions is uh, that some people say that they experience dyskinesia and dystonia at the same time. Could you speak to that? Sort of, is it possible to have both at the same time?
Yes, of course. In the benefit of those or on dyskinesias, they can be not only choreatic, but they can have dystonic jerks, and they can have peak dose dystonia in the head, because these are dyskinesias that appear during the period of symptomatic benefit of the drug. So there can be a combination of choreatic movement, jerky dystonic movements, and contractions of the neck, of the arm, of the head. It can happen, yes.
Okay. And then there's another question here about, is it possible to, would it be helpful to measure blood levels of levodopa? And, like we're doing in, diabetes, for example, we can measure, glucose levels and check them. What is the utility of that?
Well, it's not useful because the absorption of levodopa is quite erratic, and the variability in the plasma levels of levodopa is great, and it does not reflect what happens in the brain. If we were able, via some mechanism that doesn't exist at present, to measure the levels of dopamine at the synaptic level, that would be interesting, but we cannot do that. So measuring the plasma levels of levodopa doesn't make any sense.
Yeah, because it's just a reflection of what we're seeing in the blood, not actually what's going on in the brain level, basically. So,
Yeah.
okay. And then talking about, somebody's asked here about, when they have stutter stepping, so their feet are moving fast. Is that an example of, is that a dyskinesia sort of example, or is that something different?
Are you talking about propulsion and fascination?
It sounds like almost like
People
when
start,
people freeze, their feet sort of go like this. Is that an example? I think they're asking if that's sort of a
well,
question about.
yeah, well, no, no, that's not a dyskinesia. Some people, when they get stuck on a place, what we call freezing of gait, sometimes they experience like a jerky movement of the legs, and that's a myoclonic phenomenon, and it's not a dyskinesia.
Yeah.
That
Okay.
that's a totally different phenomenon.
And somebody here has written that they don't enjoy their dyskinesia at all. They would not call it a success from a patient perspective. So they're resonating with sort of your comment about how it can really affect quality of life. So I think a lot of people have felt similar with that. So so a couple of questions. I think one is also sort of getting a sense then Oscar, your algorithm. So let's say when you're talking about young versus old, or younger versus older, I guess, what is your cutoff? Is there a way that you define that in a number, or is it something that what do you take into account when thinking about that cutoff?
Well, when you decide a type of medication, first of all, it's very hard now to say who is young and who is old. I mean, because the life expectancy has expanded so much in the last 50 years that now a person that was considered to be in advanced age 20, 30 years ago now is a middle-aged man or a middle-aged woman. So it's very hard to define that. I would say biologically young more than chronologically young. And when I talk about very young, I talk about people under 50, for example. People under 50 are very young, and we have to be very careful with the use of levodopa. Between 50 and 65, it's a matter of being biologically young versus chronologically young. And there you can sometimes decide whether this person will benefit with levodopa because of the severity of the disease, or we can postpone the use of levodopa. And when a person is above 65 or 70, sometimes it it's not sensible to postpone levodopa, because the complications of levodopa tend to appear after 10 years. And so if life expectancy is around the 80s, you cannot deprive the patient of one of the best drugs we have for the symptomatic treatment of PD. So it's a matter of experience. I cannot give you strict rules. In the very young, yes. In the very young, yes.
Yeah.
I would like to make a comment about the treatment of dyskinesia that I forgot to talk about.
Sure.
And this has to do with biphasic dyskinesias. I told you that biphasic dyskinesias, or end of dose dyskinesia or beginning of dose dyskinesia, paradoxically, they can be resolved with rescue therapy. For example, apomorphine or inhalable levodopa. So whenever a patient has one of these bouts of biphasic dyskinesia, you can give a shot of subcutaneous apomorphine or a puff of inhalable levodopa. And now you have the Kinmobi, the film, and you can rescue the patient from these severe biphasic dyskinesias, because they are caused by low levels of levodopa or intermediate low levels of levodopa.
And Oscar, in your practice, when you're trying to understand these things from a patient, sort of, the timing of day and when they're getting it, is there some do you use a diary, for example, and have people fill things out, or is it verbal? How do you get a sense of when these episodes are happening?
Well, there are many diaries that are used out there to try to record off time, on time, time asleep, time with dyskinesia. But there's no single diary that properly differentiates off-period dyskinesia or dystonia, biphasic dyskinesia, on-period dyskinesia. So what we do is we try to make patients understand and try to pay attention to not only the time of day in which the dyskinesia appears in relation to the time of the dosing of the levodopa, but we also give them instructions as to the recognition of the phenomenology, because you can tell whether it's a biphasic dyskinesia or a peak dose dyskinesia by the type of movement. I mean, biphasic dyskinesia predominantly affect the lower extremities, are repetitive limb movements, whereas benefit of dose dyskinesia are choreatic or dystonic, and off-period dyskinesia are muscle contractions. So we instruct the patient to recognize this different phenomena in order to identify them. And we also talk to the carer of the patient, because one of the curious things about dyskinesia is that sometimes the patients that have benefit of those dyskinesia, if these are not too severe, they do not realize, they do not perceive that they have dyskinesia. Is the carer, is the relatives that tell them, but you're moving all the time, can you be still? And the patients do not realize they are moving all the time. And sometimes, because there is a tendency to develop what it's called levodopa addiction, or what's called dysregulation, dopaminergic dysregulation syndrome, these patients that have dopa addiction have severe dyskinesias, and they think that they have dyskinesias because they do not have enough effective levodopa, and they worsen the dyskinesia because they are addicted to the levodopa. So these things you have to take into account too. Some patients become hooked to levodopa, and it's very hard to tell them, well, but all these movements that interfere with your activities in everyday life, they are caused by levodopa. You have to reduce levodopa.
Yeah, it is very complicated. And even within the same patient, sometimes the 24-hour
Okay.
discussion is very interesting. So, quick question. So when you're starting levodopa, let's say you had talked about the judicious use of it.
Well, sometimes I ask the patient to
Can you hear me? Is this okay?
no, I was saying that sometimes we ask the patient and their families to register through a video recording the phenomenology of the dyskinesia.
Yeah, that's very helpful. So when you're starting levodopa, you were talking about the judicious use. Can you give us a sense of kind of what your average sort of idea of starting dose would be when you're starting it? You talked about starting low, starting it multiple times a day. Let's say you had, a 65-year-old woman of, relatively small size before you. What would you start her on, let's say?
I'll give you an example of the way I start levodopa on a patient like the one you talked about. If I see a patient in which I have to start levodopa, first of all, I do not give 4 doses from the beginning. I start introducing levodopa very slowly, trying to adapt the patient to each dose. And for example, I tell them, well, we have here Matopar, which is a brand name of levodopa benserazide that has 200 milligrams of levodopa. So I encourage the patient to fractionate the tablet in fourths, 50 milligrams. Start with 50 milligrams at 8 a.m. the first week, 50 milligrams at 8 a.m. at 4 p.m. the second week, 50 milligrams at 8 a.m., 12 noon, and 4 p.m. the third week. And the fourth week, complete the 4 doses with a 4th dose at 8 p.m. Why do I do that? Not only because my experience titration of the levodopa, but there is a reason. Parkinson's disease is an imbalance of basal ganglia function. If you try to modify that imbalance very rapidly, you cause a very tremendous shift in the stimulation of the dopaminergic receptors that leads to these molecular and genetic transcriptional changes. So I try to adapt not only the patient to the tolerability of the levodopa, but adapt the brain to new levels of dopamine in the brain. And many of my patients can go on with just 200 milligrams of levodopa divided in 50 milligrams 4 times a day for 1 or 2 or 3 years without the need to modify the dose. And if I have to modify the dose, I try to modify it gradually. Again, if the patient is taking 50 milligrams 4 times a day, and I have the need to increase the dose, I tell them, well, the first week you increase to 100 milligrams, in the first dose of the day, the second week in the third dose, the third week in the second dose, and the fourth week in the fourth dose, and you reach 400 milligrams. And if possible, try not to go beyond 400 or 500 milligrams per day, because the chances of developing dyskinesia are very high when you go above 500 milligrams. And the other thing is that there is something that it's not well studied from the basic research side of things, which is a phenomenon that I call induction. The more you give levodopa, the more you need levodopa. This type of phenomenon in pharmacology, and people that experience not only dyskinesia but experience fluctuations that need to shorten the intervals between each dose of levodopa, you start shortening the intervals and increasing the dose, and the patients keep fluctuating more and more. So it's kind of a no-win or catch-22 situation.
I see. That's really interesting. It's good to hear how you start that. There's been a few questions just on leg cramps at night. Could you speak to that, Oscar?
Yeah, well, leg cramps at night are in fact off-period dystonia in most of the patient. That sometimes is solved by giving control release formulations of levodopa at bedtime.
Yeah, that seems like a very reasonable approach. I want to give you the last few minutes, Oscar, to just tell us a little bit about sort of some of the more holistic approaches. I know you and I had spoke a little bit about the tango dancing that some of your community is doing in Buenos Aires. Maybe you could tell us a little bit sort of about your kind of approach to sort of those sorts of things, what you think the tango dancing may do, and if there's another secret or two maybe that you've sort of thought about. We have about 3 minutes left to kind of inspire our patients here, and I wanted to give you a chance to teach us any of your secrets.
Well, just a couple of things. You know that I'm a firm advocate of lifestyle changes in Parkinson's disease. I'm a firm believer that you need social night. You have to have good, healthy diet, because a good diet like the Mediterranean diet promotes a healthy microbiota, and a healthy microbiota prevents neurodegeneration and it modulates your immune system. You need to be psychologically well and accepting the disease, because if you do not accept the disease and share with the disease your journey, you're going to be unable to do the things that you need to do, to accept taking a medication in a regular basis, to do exercise every day, because exercise is very good. So I'm all in favor of this holistic approach to the treatment of Parkinson's disease. It's not just the medication. And it's also the contention that you provide to the patient every time you see him. Try to make the patient learn to live with the disease in a friendly way. Try to make amends with the disease. And I just saw one of the patients saying, don't all porteños dance tango. You know, porteños are the people that live in Buenos Aires. Not all porteños dance tango. I do not dance tango, and I'm a porteño. But coming to tango, I was telling you before we started this interview that tango has been shown to be very effective in Parkinson's disease. And I believe that the reason why it's very effective in the rehabilitation of Parkinson's disease, particularly balance and gait, is because tango, it's something that is not done by rote. It's not something that you memorize. It's something that you have to do it very consciously and very attentive. And whenever you increase your attention, you improve the performance of your gait and you improve your posture. So that's why tango is so successful and effective as a mode of rehabilitation in Parkinson's disease.
That's amazing. Well,
And it's not true that all Porteños dance tango, and it's not true that all Argentinians drink mate either.
well, this has been such an amazing session. It's so great to connect with you through this.
And it's not true that all Argentinians have dinner at 10 p.m.
You're dispelling many myths here. So thank you so much for your time and all of what you've done. I mean, it's just an amazing career that you've taught us about, like spanning from when levodopa was first introduced. And I really, it's so fascinating to see, your description of your evolution of thought over these many years. And it's just amazing to also hear about these patients that you've followed so closely. At your stage of your career, it's very easy to say, somebody else can do the daily phone calls and the follow-up, but I think it really makes a huge difference when you are the one to know about the intricacies of the patients and are the one to see them so often and for so many years. I think it's really telling. So I really appreciate you coming on the series, Oscar, and appreciate all that you've done for the society and for inspiring people like me. And there's many kind comments here. Hopefully the gang from PMD Alliance will forward to you. I'll just give you a second to wind up here if you want to say a message of hope to our listeners out there. And thank you again, Oscar, for spending the hour with us.
Oh, I thank you very much, Indu, for the invitation. I really enjoyed talking to you. And I think it's a wonderful opportunity to talk to people with the disease, people with Parkinson's, and give different outlooks as to the experience that many of us share. And I can tell you, there are not many people that are fortunate enough to have lived through the whole evolution of the process since the introduction to levodopa to what we know presently. So I feel fortunate to have been a witness of that evolution. And I thank the opportunities that the societies have given and my mentors have given to me. So thank you again.
Thanks. Back to you, Andrea, for a goodbye wave.
Bye-bye.
Yes. So
Bye.
Professor, we always show our gratitude with by turning on our video and doing a wave. So if you want to look in gallery view and see all the faces saying thank you for educating us and all of the work that you've done over your long, illustrious career. So thank you for joining us, and thank you to all of you for tuning in, and great questions and great discussion as always. And thanks, Indu.
Thanks. Bye, guys.
Bye now.
Thank you. Bye-bye. Bye-bye, everyone. Bye-bye.